Hi, good morning. So this morning I'm going to kick it off. It's a real privilege to talk to you guys today, and you're going to find there's nothing better than an emergency physician trying to teach you physiology this morning. So as part of the mandate, I'm going to talk about the virtues of using volumetric capnography as a monitoring tool, particularly in respiratory failure patients. We're going to talk a little bit about the single breath test CO2 waveform and how we can use the capnogram to try and estimate dead space and the virtues of dead space as a prognostic marker in respiratory failure. So monitoring end-tidal CO2 in its traditional form, i.e. time-based capnography, is in widespread use in hospitals. In the emergency setting, it's used for confirmation of endotracheal intubation. It's used to look at the efficacy of chest compressions. And moving on from that, in anesthesia, continuous time-based capnography is ubiquitous. It's slowly also integrating its way into critical care practice. It's almost standard of care now for inter- and intra-hospital transfers. And in a recent document released by the Intensive Care Society, they strongly recommended that we should use continuous capnography for all mechanically ventilated patients, albeit this was based on common sense rather than any hard evidence. So the conventional time-based capnography, well, there are several advantages to it in that we're familiar with it, it's widely available, and we've all sort of made an initial investment. But in comparison to volumetric capnography, there are some things which we can't do, and we can't qualitatively analyze the different phases of the capnogram as well as we can in volumetric capnography. And also we're unable to decipher any meaningful quantitative data about dead space and its components from time-based capnography, which is why volumetric capnography is advantageous. Really, the kit is quite simple. It's an amalgamation of a flow sensor and an infrared capnograph, which is connected mainstream just distal to your ET tube. And what this does, it's in real time integrates flow with concentration of CO2, and that gives you CO2 as a function of volume, and that's where the advantage is. So aside from measuring end-tidal CO2, because you're integrating flow and concentration, what you have is volume, and it gives you a much more accurate measurement of what your true expired tidal volume is. It also gives you the volume of carbon dioxide excreted, or your VCO2, and you're able to calculate dead space fraction and its components. So the capnogram of volumetric capnography looks very similar to time-based capnography. You've got phase one where there's no CO2. You've got the sharp sigmoid that sees the rapid rise in CO2 concentration followed by the plateauing of CO2. Now, looking at each of these phases individually, the first phase is almost entirely from the upper airways, and there's no CO2 detected. If you've got a prolonged phase, what that normally suggests is that you've probably got a large volume of anatomical dead space or airway dead space. And that's very easy to look at in this because all you have to do is just map where your phase 2 starts. And the point of where your phase 2 starts is the volume of which you've got true dead space. The next phase is phase 2. This is a sigmoid shaped in a very small space of volume. You've got a huge rise in concentration. And what this signifies is the transition from airway dead space to alveolar dead space. You're transitioning from a part where convection is in the primacy for gas transfer to an area where diffusion predominates. And then finally, you've got the slope of phase 3. This normally should be flat. And this basically is gas. This represents gas from the alveoli. And in some ways, looking at this is where we get the most meaningful information in terms of just eyeballing the patient or qualitative assessment of the waveform. So really what one would expect in normal breathing lungs is a very square-shaped capnogram. And if you've got homogeneous lungs where they're emptying at the same time and there's synchronous emptying of your alveoli, you would see a short phase 1 and then a very sharp phase 2, so in a very small volume difference. So the delta volume is very small. You see a sharp increase in concentration of carbon dioxide followed by a very rapid plateauing. However, as soon as you develop inhomogeneity in your lung emptying, if you're seeing a huge VQ scatter in intra-alveoli, or there is variance in time constants, you'll start to witness that your phase 2 becomes lazy, and the gradient of your slope of phase 3 starts to increase. And all these are features of lung injury or ARDS. So just to illustrate it with examples, these are sort of cases that data we've collected previously. This is a patient, an obese patient undergoing elective surgery, and this is the capnogram here, and as you can see, phase 1, there's no gas detected. Phase 2, there's a rapid increase in CO2 over a very short volume, and there's plateauing of phase 3. In contrast, comparing this with a patient who's got COPD, who was ventilated because of pneumonia, as you can see, the slope of phase 2 is slightly lazier, and there is a tiny gradient in phase 3. And this is probably to compare what one would expect a normal capnogram to look like for this patient. Progressing on, we've got a patient with very severe VQ abnormality. So this is a patient with ARDS. Now the thing to note here, really, you could argue that there's a continuum in the slope of the capnogram. What this suggests also that it's very difficult to differentiate where the transition point is between phase 2 and phase 3. And this is a feature that you will see in your capnogram. And just by eyeballing, you can tell that you're looking at lungs where there is great intraalveolar inhomogeneity. And this is what it would look like normally. So the question is, when we are monitoring patients for ventilatory failure, are we measuring the right variables? So in terms of if we're looking at alveolar PCO2, and in this case we're substituting it with arterial PCO2, the two variables that we know that influence alveolar PCO2 or arterial PCO2 from a ventilation perspective are CO2 production, VCO2, and dead space. The rise of either of these two variables will result in an increase in the arterial PCO2. However, we don't measure either of these. And volumetric capnography is a very simple bedside measure of both of these variables. So particularly going forwards in this talk, I'm going to focus on the value of measuring dead space. This is a paper from 2002 by Nuckton and colleagues, which was published in the New England Journal. And they looked at dead space ventilation as a prognostic marker in ARDS. And as you can see from this graph, there is clearly a biological argument to show that a high dead space is associated with worsening prognosis. There have been several studies subsequently that have looked at dead space or a surrogate of dead space and looked at it as a prognostic marker in ARDS, and all of them have consistently shown that it is associated with mortality and is an independent predictor of mortality. Some of these studies have also looked at dead space over time and found that sequentially increases in dead space is a worse prognostic marker. Again, we seldom measure it. So I'm going to go through a little bit about the physiology of measuring dead space. The equation at the top here is sort of the time-honored Enghoff modification of Bohr's equation, and the measurements that you need to calculate or estimate dead space fraction are arterial PCO2, which in this case has been substituted or used as a surrogate for alveolar PCO2, and you've got mixed expired PCO2. And herein, I think, lies the problem as to why we don't measure dead space fraction. And for those of you who've ever engaged with a Douglas bag, which is what you need to collect, which you need to calculate dead space, you can see it's cumbersome and just annoying. And I'd be happy if I never see another Douglas bag in my life. So what volumetric capnography does is it gives you a very easy estimate of your mixed expired PCO2. It does so simply by dividing your CO2 production per minute by your minute ventilation. And that gives you a fraction of your concentration of CO2. And you can use that to calculate your physiological dead space. However, an alternative way to view dead space is a part of its components. So physiological dead space is alveolar dead space plus your airway dead space, or what's traditionally known as anatomical dead space. Now, volumetric capnography, because you're plotting concentration against volume, allows you to engage with the volume in such a way that you can actually use the waveform to calculate these individual components. And over the next few slides, I'm going to talk about how we do this. So what you see in this graph here is a simple capnograph. The points A and D on the x-axis represent the start and end of expiration, respectively. The line BC corresponds to what your measured arterial PCO2 is, and we plot that on the y-axis. And what you've got here is an area A, B, C, and D. And this represents the total area, so this is the proportion of the total area of your tidal volume, or a single breath. Now, the area that's shaded here, so area X, represents the portion of that volume that's participating in gas exchange. That's alveolar ventilation. And quite simply, the rest of it is physiological dead space. So that makes it quite easy in some ways to visually interpret what our physiological dead space is. So going back to, this is our patient who was undergoing elective surgery, and we plot the arterial PCO2, and we've got our areas A, B, C, and D. And the shaded area now represents the portion of that total area which is your physiological dead space. Moving on to a patient with COPD, the previous patient had a measured dead space of 0.4, dead space fraction of 0.4. This patient has a measured dead space fraction of 0.6. We enter our arterial PCO2, and the shaded area here now represents the portion of the total breath that is dead space, and in this case it's 0.6. We go to a patient with ARDS, and this shaded area is much bigger. And this is the basic principle that we can use the CO2 waveform to work out what a physiological dead space is. Now, this work was done by Roger Fletcher, and he published in 1984 in the BJA, and really there's a seminal paper, and it's really progressed the technology, and increasingly we're using it more and more. And the second clever thing that he did was to add an extra degree of sophistication. He incorporated Fowler's method of measuring anatomical dead space, which was initially done on the single breath test of nitrogen, and incorporated it into CO2 waveform, such that phase 2 gets split into areas P and Q, where both these areas are equal. And now if we incorporate that into our areas A, B, C, and D, what we have is that the whole portion of tidal volume split into 3 distinct volumes and areas. First of all, we've got area X, which remains the area of alveolar ventilation. Then we've got area Z, which is the grey shaded area, which represents anatomical dead space. And finally, we've got area Y, which is the striped area, which represents alveolar dead space. So put quite simply, areas Y plus Z divided by the total area gives you physiological dead space. And area Y divided by the total area gives you alveolar dead space fraction, and area Z divided by total area gives you anatomical dead space fraction. So the good news is, and there is good news, that if you enter your arterial PCO2 value, most of the machines that have capacity to measure volumetric capnography does these calculations for you. But I thought it'd be good to just go through it. Right, so the next question is, does this really work, and how does it compare to the conventional method of measuring dead space? And a little bit of shameless self-promotion. This is a wonderful paper. You must all read it. I'm sure none of you have. It's particularly helpfully been put under the physiological and technical notes, which is a no-no to even the most hardy of readers. But what we did here simply was in a wide spectrum of patients, in 48 patients, we measured dead space using both the conventional method and the unconventional method. Now, one of the drawbacks of using the Douglas bag is that the mixed expired CO2 often gets contaminated by the compressed gas in the ventilator circuit, and it can underestimate the value of mixed expired PCO2 and overestimate dead space. So in order to use it, you have to use a correction factor, which adds further to the complexity of this method. Now, we arbitrarily measured this in patients. We used a convenience sample, and we arbitrarily measured this in patients who we anticipated would have a wide variety of VQ mismatch. We anticipated them to have a wide variety of VQ mismatch. We used patients with respiratory failure, which we again said were any patient that had an admission PF ratio of less than 40 kilopascals. As you can see, these patients were fairly unwell, and the mean dead space of the population was 0.6, and we took sequential readings in various ventilatory settings using volume-controlled, pressure-controlled ventilation and pressure support ventilation. And actually, the idea of the study was to see whether or not, over a wide degree of ventilator settings, whether the two methods were in agreement. And by and large, we found that there was good agreement using volumetric measuring dead space using volumetric capnography and using the traditional methods. And the mean bias was less than 5% for both the corrected and the uncorrected. Similarly, we looked at mixed expired PCO2, and again, we found good agreement with the traditional method and the values that were derived by volumetric capnography. There are, of course, other studies which have looked at using volumetric capnography to measure dead space. They're in slightly different clinical settings. However, by and large, everyone concurs that there is good agreement between the two methods of measuring dead space. So, however, it's not all good news. There are some problems with using volumetric capnography, and one of them being that in patients with very sick lungs, particularly if you've got dead space fraction of greater than 0.8, which is actually vanishingly rare, but it does occur, in those instances, the software program that actually calculates dead space fails because it's not able to differentiate the transition between phase 2 and phase 3, and that's sort of a fault of the way the mathematical, the way the mathematics are programmed into the software. The second thing is, and this is a caveat that goes with any measurement of dead space that uses arterial PCO2 to measure alveolar PCO2, is that there is a factor of interpulmonary shunt, which causes your PCO2 to be falsely elevated. I say falsely in that it's not true dead space, and it becomes less clear what it is that you're measuring. But what you can say with confidence that someone with a high dead space fraction, as we measure it, has got serious VQ abnormalities. And finally, if you've got disruption of flow, so if you've got a patient on a nebulizer or on continuous nebulization, then in that case, volumetric capnography fails as well. So finally, I'm just going to touch upon a few other ways that dead space can be used in respiratory failure. So it's been used as a marker in recruitment studies and prone positioning, and several of these studies have found that people in whom there is in whom PCO2 falls following either recruitment maneuver or prone positioning are more likely to, number one, more likely to probably go on to survive. So those patients who are PCO2 responders, i.e. in whom there's an improvement in ventilation, have a better response to prone positioning. And also there is, in the second study by Pratik and colleagues, they've shown that there's a greater association of improvement in ventilation or ventilatory efficiency with changes that they've seen in CT scanning. The last study, which is a very small study, they've looked at dead space compared to other respiratory variables in prone positioning and found that it's more meaningful in terms of charting patient improvement, and it's also more time sensitive, so you get a response much quicker than markers of oxygenation. People have also used dead space to look at optimization of PEEP. In the first paper by Suter in 1975, published in the New England, sort of a real seminal paper. And effectively, the theory behind it is that if you've got sort of inhomogeneity in your alveoli and your alveoli are closed, what you get is inefficient ventilation, and that leads to a high dead space. As you open up the alveoli, you're getting better VQ matching, you're getting more homogeneous ventilation, and your dead space would drop. But then as you over-distend, relative to the amount of perfusion that you have, alveolar units are over-distended, and you've got high VQ, and that subsequently leads you to having a high dead space. So you can use dead space as a variable to optimize what level of PEEP to use. This theory has been validated and used in animal models by Tisman and colleagues, in anesthetic patients and in patients with respiratory failure as well. Finally, I'm going to touch upon the virtues of using CO2 production. I mean, it's a very useful variable, particularly in those patients who you're struggling to ventilate and you're really at the cusp of where it is acceptable, the levels of pressure that you're delivering, and you're at the cusp of protective lung ventilation. Well, I mean, the beauty of using CO2 production as a marker is that it's only exclusively produced in the mitochondria. And so it can be used as a marker of metabolism, particularly once you've reached steady state. The CO2 rate of CO2 elimination equals the CO2 production. And we know CO2 production goes up with certain conditions such as fever, agitation, shivering. High-calorie diet has also been implicated with giving you a higher VCO2. So there are certain strategies for individual patients, and I'm confident that you'll never be able to prove this in big studies, but in certain patients you can actually tailor their needs in terms of sedation, paralysis, or targeted temperature control to lower their VCO2, and that would give you an advantage and allow you to perhaps carry on with your ventilatory strategy. And also in patients with extracorporeal CO2 monitoring, VCO2 offers a very simple way to look at the workload of your workload of your CO2 removal membrane and monitor its efficiency over time. So in summary, volumetric capnography measures your end-tidal CO2. It measures your rate of CO2 elimination, or your VCO2. It gives you a much more accurate measurement of the actual expired tidal volume and your minute ventilation. Volumetric capnography also calculates physiological dead space and its components. Qualitative assessment, so just eyeballing the capnograph, gives you some useful information about the state of the lungs and the state of ventilation. Dead space is consistently proven to be an important and independent predictor of prognosis in ARDS. And whilst the studies have been very small, with that caveat, but it's a relatively new technology, there seems to be a signal to suggest that in PEEP titration, in optimizing recruitment and prone positioning, there may be a role going in the future for dead space as a tool to optimize these interventions. Thank you.